How can a needle so small cause enough damage to create a pneumothorax? We'll talk about it. Be sure to watch the ending where we see an intraoperative video of the lung expanding and striking a catheter that is indwelling into the pleural space. That portion of the video begins at 6 minutes and 12 seconds. Here's a picture of a pneumo. So this lung should be all the way out to the side of the ribs. When you take a deep breath, when you get a chest X-ray, you take a deep breath and then you hold your breath and they shoot the chest X-ray. They do that because the lung is expanded, and that's how they can visualize your lungs when you get a chest X-ray. Now, a pneumothorax is not you like sticking something in the lung and it's like a balloon and then all the air lets out of the balloon and the balloon's deflated. That's not really what happens with a pneumothorax. A pneumothorax happens because air comes into the pleural space. So you get a hole through your chest wall, air enters your pleural space, then the air gets stuck in your pleural space. And because there's air stuck in your pleural space, the lung cannot expand against the pressure of the air inside your pleural space. It just can't overcome the pressure that's built up inside your pleural space. So the lung then, quote, collapses because it can't expand when you take a breath. That kind of makes sense? I tell you what doesn't make sense though. Have y'all all seen a dry needle and like how tiny it is? Mm-hmm. So we usually use 0.30 millimeter dry needles or smaller. That's smaller than a pencil lead. It does not make sense how that could enter your pleural space and then allow air to come into that pleural space. Think about the layers that needle would have to go through. Let's say that we're just on your back and we needle you in your periscapular region. So it would go through your skin. The needle would have to go through your skin. It would have to go through whatever back fat you had. It would then have to punch through some muscles. So it would punch through your middle trap, punch through your rhomboids, potentially your serratus posterior superior, and then if the needle happened to be lined up with a rib, it would have to punch, or lined up in between a rib, it would have to punch into the intercostal muscles. Then it would have to puncture the pleura before it ever even got into your pleural space, right? That's like 7 or 8 layers that I just named. And then when the needle came out, there would have to be a hole left for air to get into the pleural space. That doesn't make sense. Like with something that small, it doesn't make sense that air could get through a hole that small. I feel like you could make a hole that small, put your mouth over the hole, blow as hard as you could, and you still could not get air to go into the pleural space. So how in the world could you get a dry needling pneumothorax? So likely what's happening is when the needle comes into the pleural space, you know how when we breathe, our lungs expand and they deflate, so they inflate and they deflate. If you've got a needle inside this pleural space and then your lung is expanding, inflating and deflating, if the needle's inside your pleural space, it's likely hitting this needle. And then as you breathe, it continues to hit the needle that's inside your pleural space. What's the average rate of breathing? It was like 20 respirations a minute or something. So 20 times a minute, that needle the lung hits the needle. And if you have a needle inside somebody for 10 or 15 minutes while you're doing E-stim or something, let's just say it was for 10 minutes, that's 200 times that the lung hit this needle. So with that happening, the lung can then develop a hole. And because the lung gets a hole in it, because the lung was poking the needle that was in the pleural space, then air can exit the lung because there's a hole in it. When air exits the lung, and then that fills up the pleural space, then again, you've got air inside your pleural space, so the lung cannot expand against the pressure of the air built up inside the pleural space, and then you get a pneumothorax. So I think that's probably how pneumothoraxes happen when it comes to dry needling pneumothoraxes. There's certainly some places that increase your risk for pneumothorax with dry needling. People talk about the upper trap a lot, and you could do the upper trap incorrectly and get into somebody's pleural space. Here's a fantastic example of what not to do when you're dry needling the upper trapezius. You would never direct the needle towards the lung field. This video is publicly available via Instagram on some sports chiropractors out of Chicago's Instagram page, and just demonstrates a terrible technique with such risk to the apical segment of the lung and the chance for pneumothorax. But most likely, the areas that tend to be more risky for pneumothoraxes would be people trying to do rib block techniques, where they try to put a finger on each side of the rib, and then they're trying to bracket the needle straight down towards the rib. That's just asking for trouble.
and then some of the periscapular muscles like your rhomboids, certain serratus muscles, thoracic paravertebral muscles. If you get too wide and you're outside the protection of your paravertebral gutter and you're too wide and then you send your needle down, if you're not in the paravertebral gutter, then you could be in between ribs and get a needle into the pleural space that way. And then lower cervical paravertebral muscles, same kind of thing. You're a little too wide and then you're outside the protection of your laminal bony backdrop, you could go into the pleural space. And then once that needle enters the pleural space, if the lung's hitting it, the lung can get a hole in it. Very similar to what happens with what's called spontaneous pneumothorax, which means that the lung develops a hole on its own. So it has like a bleb or something, and the bleb ruptures, and then air leaves the pleural space. Air leaves the lung, goes into the pleural space, and the lung cannot expand and gets the pressure built up inside the pleural space. That's called a spontaneous pneumothorax. So same kind of thing. The lung gets a hole likely because of the needle in the pleural space, and the lung, as it inflates, it just continually hits the needle and then develops a hole. Likely that's how we see pneumothorax as an adverse event with dry needling.
The following is a video example of a catheter insertion into the pleural space to release trapped air causing a pneumothorax. As the pressure is relieved and the lung is able to inflate, notice how the lung continually strikes the indwelling catheter. This video is by Dr. Alexander Lincheski. You're looking in somebody's chest wall with a video thoracoscopy. They're inserting a catheter into the chest wall to remove the air, to allow the air to be released from the chest wall. This patient has a pneumothorax. So you can see the lung kind of at the bottom of the screen starting to rise up a little bit. The air is leaving via this white catheter that's being left into the chest wall. And as the air leaves and the pressure is relieved, the lung starts to be able to inflate again, and the lung is expanding, and it's expanding up towards that catheter. And now you're about to see it start hitting that catheter. So imagine if this was your dry needle in someone's chest wall, and as the lung expands, as the patient breathes at a rate of about 20 respirations per minute, that lung is going to hit that needle 20 times per minute. Well, that's a good example there. The lung really strikes that catheter, and if that was a needle, it would be poking a hole in the lung.